Hello, good morning to everyone. I want to tell you about physical rehabilitation about the topic that is multiple sclerosis. इसमें क्या होता है इज ए क्रोनिक इन्फ्लामेटरी demyelinating disease of the central nervous system. This is the disease in which chronic inflammatories occur, and it is done in autopsy. Using autopsy studied her different hardened plaques, and in epidemiology, that is, it occur at the age between 15 and 50 years. It was at the peak of the age is 30, and this topic is necessary to understand about Australian Physiotherapy Council exam. And after that I will tell about the etiology of that, which is the unknown in MS. And it is an autoimmune disease in which infectious agent is given, that is herpes virus, first, second and fourth. And pneumonia are the agent of the greatest interest in an infectious hypothesis. After that I will tell the risk is at 3 to 5 patient, co-twin to 26% for 2 5 for a co-twin, but rises 26% identical co-twin. Then I will tell about the pathophysiology. The immune response trigger production of T lymphocyte, macrophages, immunoglobulins, and a command trigger protein. The antigen is activated, producing autoimmune effects within the CNS, blood brain barrier. And after that I will tell about the clinical course, in which MS is highly variable, unpredictable from person within a given individual hour time, benign MS. And there are different types of terminology used to describe multiple sclerosis. Relapsing remitting MS, that is known as RRMS, characterized by full recovery or remaining neurological signs and symptoms, are characterized by progression. After that, PPMS, that is the temporary minor. And after that I will tell about the progressive MS. Occasionally minor remissions is occur in this MS. And after that, last, second last and third last is there progressive relapsing MS. Without clear acute relapsing may or may not some recovery or remissions, commonly seen in people who develop 40 years of age, characterized by mild disease in which patient remain fully functional in all neurological system after disease onset, characterized by progression leading to significantly disability or death within a relative short time after onset. Exacerbating factors. MS relapse are defined by new recurrent MS symptoms. The last at least 24 hours are unrelated to another etiology. Several factors have been identified. Avoiding these aggravating factors is important in ensuring the patient optimal function. After that, I will tell that pseudo expression and clinical manifestation depending on the location of specific lesions. Episode of double vision, paresthesia progressing to numbness, weakness, fatigability in more advanced stages. MS are presented in box. Onset of symptoms can develop rapidly over a course of minutes or hours. Sensory changes. Any single sensation is rare. Focal deficit can produce limited set of diminished sensation, altered sensation. In this, most important topic is the common symptom in multiple sclerosis. First is sensory system, in which hypothesia, numbness, paresthesia, and then pain, optic trigeminal neuritis, Lhermitte chronic pain. After that, visual symptom, blurred double vision, diminished loss of vision, nystagmus, Cognitive symptoms: memory decrease, attention, diminished abstract reasoning, diminished problem, diminished speed of information, diminished visual spatial abilities. Emotional symptoms: pattern of symptom, motor symptoms, and pain. 80% of patients with MS experience pain, with clinical significant occurring in about 55%. Half experience chronic pain. Patients often experience acute paroxysmal pain characterized by sudden spontaneous onset. Pain are described as intense, sharp shooting electric shoot like burning. The most common types are trigeminal neuralgia, headache, trigeminal neuralgia, result from demyelination of sensory division of trigeminal nerve, innervating the face, and for example, a light touch or light pressure stimulus elicit a severe pain reaction. Headache is more frequent in MS than in general population and can be migraine or tension type. Chronic neuropathy pain can result from demyelinating lesion in spinothalamic tracts or in the sensory roots. Visual changes. Visual symptoms are common with MS. 80% of patients. Optic neuritis, inflammation of optic nerve, dark spots, and 4 to 12 weeks there is vision problem in MS patient. Eye movement can be distributed in a variety of nystagmus and motor dysfunction. That is the weakness. Weakness with patient corticospinal lesion, and there is the problem in spasticity, balance and coordination, fatigue in mostly muscles. It is daily experience. 70 to 95% their muscles feel fatigue, and it will be the central problem and ambulatory problem in that kind of patient. And spasticity is occurring mainly they are not able to walk, like 80% of all cases. ADL spasticity can cause disabling contractures, abnormal posturing, problem in maintaining skin integrity, balance and coordination, demyelinating lesion in the cerebellum producing symptoms: dysmetria, dyssynergia, cokinesia, and this is the main problem. After that, ambulation and mobility, speech and swallowing dysfunction, cognitive affective changes, depression, and these are the main symptoms in which 50% of individual experiencing MS and affective changes. Pseudo bulbar affect, emotional dysregulation syndrome, it occur. And after that, euphoria, autonomic changes, cardiovascular dysautonomy, bladder dysfunction, bowel dysfunction, sexual dysfunction. Diagnosis: imaging, cerebral spinal fluid, evoke potential. There is cerebral spinal fluid, and diagnosis is occur by you can go through MRI, CSF. If you are evoked potential EP, then you are justice that you are having MS. And MR is a sensitive tool for confirming disease when used along with other clinical. CSF MRI detects both acute and chronic lesions, small and large, with high resolution. These scans are used to help distinguish new lesion with active inflammation that occur during preceding 6 weeks or so. Lesions are seen as areas of increased signal intensity. Bright spots, T2 scans, are used to detect more long-term disease activity. And cerebrospinal fluid, this is 80 to 95%. Patients with PPMS have higher of immunoglobulin in spinal fluid than patients with RRMS. Up to 90% of individual MS demonstrate abnormal evoked potential. The presence of demyelinating disease and diagnosis criteria of MS. This is the main diagnosis you can go through. And what is the prognosis, मतलब patient कितना curable है, we will go through that. Only small percentage of patient. Please like, follow and subscribe the channel, and I will give more information about other topics which you want to learn. Tell me.